So welcome everyone to the second Global Nexus Conversations program that we're putting on. My name is Jerry Wright. I'm the lead for Global Nexus right now at the McMaster University. We're recording this, so hopefully for those of you who are online, you'll be able to look at it again, and for those of you who aren't, then you will be able to look it up later. We're really excited and thankful to our participants today to talk about the vaccine. But before I turn it over to Dr. Leslie McNeil to moderate today's session, I want to remind us all that McMaster sits on the traditional lands of the Haudenosaunee and Anishinaabe nations. When we say this, we acknowledge the debt that to those who were here before us and recognize our responsibilities as guests to respect and honor the intimate relationship of the Indigenous peoples have to this land that McMaster stands on. So with that, I'd like to welcome or introduce Dr. Leslie McNeil, one of our faculty members in the Department of Biochemistry and Biomedical Sciences, and also a lead here for the Global Nexus Initiative to take it away and introduce our speakers for today. So thanks everyone for joining, and over to you, Leslie.
Thank you, Jerry, and welcome everyone to our second Nexus conversation, the vaccine, understanding factors in vaccine uptake. Before I introduce our panelists, I want to remind our audience that you can ask questions at any point in our discussion by typing them into the Q&A. I will quickly introduce the panelists, but we also have more extensive information about them that Jen is going to add to the chat, so you can check that out. And with that, it is my great pleasure to introduce today's panelists. Our first panelist is Lydia Joy Marshall. She earned a Master's in Science in Human Genetics from the prestigious Howard University. She is president of the board of directors of Black Health Alliance, a not-for-profit organization whose mission is to reduce the racial disparities in health outcomes and to promote health and well-being for people from the diverse Black communities in Canada, with an emphasis on broad determinants of health, including racism. Ms. Marshall also works with Health Commons Solutions Lab, which focuses on equitable solutions to addressing population wellness, including supporting marginalized communities during the current pandemic. She's diligently working to galvanize leaders to promote health awareness and patient advocacy from within the community, and I encourage everyone to go out and watch her TEDx talk, Being Black in Canada is Making You Sick. Thank you, Lydia Joy, for being here. Our second panelist is Dr. Rohan D'Souza. He is an associate professor with the Departments of Obstetrics and Gynecology, as well as Health Research Methods, Evidence, and Impact at McMaster University. He is a specialist in maternal fetal medicine. His research interests include incorporating patient preferences into clinical decision-making and improving outcome reporting in pregnancy studies. In addition to his extensive research program, he is part of a team led by McMaster that was funded by PHAC, the Public Health Agency of Canada, to improve vaccine confidence among pregnant and postpartum Canadians. Thank you, Rohan, for being here. Our third panelist is Dr. Emil Joseph, who is an associate professor in the School of Social Work at McMaster University. He currently holds a professorship in Equity, Identity, and Transformation from the Faculty of Social Sciences and is the academic director of Community Engaged Research and Relationship with the Office of Community Engagement here at McMaster University. Dr. Joseph has served on the Vaccine Readiness Network with Hamilton Public Health since December of 2020 and helped to establish the Restoration House Clinic for prioritization of hard-to-reach Black, racialized, and disabled Hamiltonians for COVID-19 vaccines. Thank you, Emil, for joining us today. Our final panelist is Dr. Mark Loeb, who is a professor in the departments of Pathology and Molecular Medicine, as well as Health Research, Evidence, and Impact at McMaster University, where he is Canada Research Chair in Infectious Diseases. Dr. Loeb is an infectious diseases physician and medical microbiologist. He is co-director of the McMaster World Health Organization Collaborating Center on Infectious Diseases, Research Methods, and Recommendations. Dr. Loeb has led cluster randomized trials of influenza vaccination in Hutterite community, establishing the importance of herd immunity. Thank you, Mark, for being here today. So thank you and welcome to all our panelists. And thank you for joining in the discussion today. Again, just to remind everyone, we have more extensive bios for our panelists in the chat if you would like more information. And as we allow our audience some time to type their questions into the Q&A, I will start off by asking our panelists to draw on their own unique experiences and expertise to tell us, in your experience, what factors play the most important role in vaccine uptake. And we'll start off with Lydia Joy.
I get the honor of going first. Thank you. When we say from our experience, there's so many positionalities we bring into this answer. I think personally, it has really been, what myself and community view as health. So it's been very interesting. I think what has been the most fascinating for me is hearing this all, we're in this together, right? This is how it's all started. This is how the conversation started. And many, especially from my community, we have not been part of this healthcare system for a very long time. And what we view as normal, what we view as how to take care of our health, there's so many different factors that are involved in that. And so, we skip and we're so focused because of the pandemic on vaccines and one form of medicine, but we have such a holistic view. And I think that has influenced the most what we view as what it means to be healthy, it sounds very strange, but that doesn't only mean in life. That might mean peaceably living with something, that might be peaceably passing, that might be how we consider ourselves to be healthy while we're going through it. It also, what is really influencing our communities is our trust of this system, whether we are 9th, 8th, 10th generation Canadians, many of us are intersectionally Indigenous to these lands also. Some of us are immigrants, some of us are first, second generation. But the trust system of who is creating the vaccines and medications and pharmaceuticals, we have a long history of that not having been the we for us was not a positive, whether that is being tested on, not tested with, or whether that just the treatment in medical facilities right now are not felt respectful. I know often when we have this conversation, we would defer back to big trials and things that people have heard that we assume causes mistrust. But the biggest mistrust is actually currently going through the medical system. Many people in especially the Black community don't feel respected or valued or their values valued. And so when things are rolled out, we don't automatically assume that it's within our best interest. So that's the Coles notes, I would say, of what influences or how we feel around that. But I think truly there's such a cultural impact that's beyond what's often in the mainstream narrative of what influences our choices.
Thank you, Lydia Joy. That was really a really great summation of reasons why different communities may have hesitancy and how they view risks. And I think also our next panelist, Rohan, you're going to tell us also about a different sort of evaluating of risks for different communities.
Yeah, thank you so much. I've got a couple of slides, and I thought maybe I should give you some context about pregnancy and lactation, because not everybody is familiar with the nuances of pregnant and lactating individuals. So what happens with pregnancy and lactation is we're dealing with generally a relatively young and healthy population. And although in high resource settings now, we do have 1 in 4 people coming into pregnancy with some kind of comorbidity, that is diabetes or blood pressure or some other medical illness, the vast majority are young and healthy. Many have never ever seen a doctor before. They feel invincible, they feel well, they just feel like they're going through a part of life. What happens during pregnancy is very rapidly there are changes, not just physical changes, but physiological changes. And these changes involve the respiratory system, the cardiovascular system, immunologic system, hematology. And as a result of all of this, pregnant individuals are at an increased risk for a number of things that they were not at an increased risk before. One of the other things to remember about pregnancy is, unlike many of the other risk factors like age or diabetes or blood pressure, this is a transient state. And so a lot of pregnant people feel, you know what, if I just wait this out, I'm going to be fine. And so I can then probably think about taking the vaccine later. But the problem is that the real risk is not later. The real risk for a pregnant person is now. It's at the time when they are pregnant. And and clouding everything or overriding everything is the person's concern about the effects of anything they take on the unborn child. So there are all these factors that come into play when dealing with pregnant individuals. What we do know is, and this is just one of the publications out of Canada talking about the risks of COVID in pregnancy, is that if a person that is pregnant does get COVID, then they are at an increased risk of many maternal and neonatal and fetal complications. And I've just listed a few. The problem with pregnant individuals is that there is a reluctance to include pregnant individuals in trials, and therefore randomized trials on the vaccine did not include any pregnant individuals. And even when pregnant individuals are included in trials, they tend to be second and third trimester. Now, most of the adverse fetal effects related to structural abnormalities, etc., happen in the first trimester, and we have very little information that comes from trials. And what we need to rely on, therefore, is the post-licensure assessment of effectiveness and safety, which always takes time. What also doesn't help is inconsistent messaging. When the vaccines were rolled out initially, there were at least 2 organizations that said pregnant people should not take the vaccine, and some other organizations that said pregnant people should take the vaccine. So that kind of inconsistent messaging has not helped either. Currently, there are at least 13 countries that do not recommend the vaccine for pregnant individuals. Over time, we've now got a lot of data on the safety and effectiveness of COVID vaccines, and I've just put a couple of these publications on the screen. But what I'd like to say is that pregnant individuals are generally a vulnerable population. There is the fear of the unknown, and it feels like it's everybody's business to inform a pregnant person what they should and shouldn't do. They feel influenced by society, by family, by peers, by religion, by culture, by a lot of other things. And so decisions that are made are generally not always only their own. And there are unique concerns that they have about the vaccine, which are related to miscarriage, menstrual changes, infertility, malformations, long-term effects on the baby, and then, of course, the other things that affect every other individual, that is, was this vaccine rushed, and all the other misinformation that there is. And this gets worse when we start adding on to this the layer of racialized, marginalized, indigenous populations and equity-seeking groups. What is lacking is information being consistently given over to people through trusted sources of health information. And the role of the pregnancy care provider is very, very important, but a lot of pregnancy care providers are so burnt out that they find it hard to keep communicating the same message with the same zeal as they did earlier on in pregnancy. So we've done a little bit of work on this, and I'm not going to go into the details of it, but we've looked at the theoretical underpinnings of vaccine hesitancy in pregnancy and factors that influence the uptake of vaccines. And what we were able to do was to identify that all of the factors that influence uptake in the pregnant individual can be nicely packaged into this social ecological model. And what I mean by that is that there are a number of things that can be done and that have been tried in the past. And these include interventions at a personal level, that is educating patients, at an interpersonal level, that is shared decision-making tools between the trusted source of information and a pregnant person, institutional factors that include provider education, best practice alerts, standing orders, increasing access and availability, community interventions in some instances like home visits, policy interventions like national guidelines, providers, toolkits, and most importantly, a combination of all of these, which is bundled interventions. Well, that is my response to that question. Thank you.
Thank you, Rohan. I'm glad you mentioned also the crossover between different groups that are hesitant, perhaps for different reasons for vaccination. So you mentioned pregnant people, as well as people from groups who have reasons maybe to distrust healthcare. And so I think maybe we'll hear a little bit more even about that from Emil.
Hi all, thanks for having me. I think, some of the ways that we describe, vaccine hesitancy, vaccine confidence, vaccine readiness, obscure some of the complexities that are before us and then have been for some time. When I was invited to participate in the Vaccine Readiness Network in Hamilton, it was initially established as a way to bring together community health leaders and community organizational leaders to get a broader perspective of how to do outreach well. And what happened early in the pandemic was, a situation where there were overlapping historical concerns that were quite complex, some of which Lydia Joy mentioned in relation to systemic mistrust of health systems and services, and how that impacts this ask of health systems to have people trust them all of a sudden. And I think it played out in a lot of these conversations early as well. Early in 2021, there was some data that was shared around infection rates in Hamilton. And there was close to 50% of infections that were impacting Black, Indigenous, and other racialized communities. And in some of these conversations at the Vaccine Readiness Network, there were repeated asks about what is being done to prioritize those most impacted and how. And when movement didn't occur, that turned into some organizing and some advocacy. Eventually, when further progress wasn't made, some of these groups rallied together: community health centers, community organizational leaders, members of Black, Indigenous, and racialized communities wrote a letter to the entire network and public health, asking for action. When that wasn't responded to, they went public with it. Over 500 other Hamiltonians signed on in support of action. And it was when that kind of thing hit the media through the advocacy that there was an agreement to do some things differently. And it was those very community leaders. You have the Hamilton Center for Civic Inclusion, the Disability Justice Network of Ontario, and all of the community health centers. So the Hamilton Urban Core Community Health Center, Compass, Centre de Santé Communautaire, Refuge, Community Health, who all came together to agree to take on the work, because they do the daily work of attending to those most marginalized by health systems, and they do it well. What they wanted was the freedom to do so, and the acknowledgement that these problems have a historical basis, and that we need to do more to inform people better. They developed the Restoration House Clinic for Indigenous groups. The Perkins Center had a clinic with Droit de Desne, and it was incredible. They've vaccinated thousands of people, and there's a lot of learning there. I think the way we think about who does this work well, how do we engage in processes that trust at the forefront, that trust at the beginning, that there are people out there that know what kind of responses are necessary. They advocated for a vaccine ambassadors program. Black health leaders asked for resourcing in a way to have difficult conversations in communities. There were advocates who were rallying around prioritization of lower income communities and increasing the amount of FSAs, the actual geographic areas that were being targeted in vaccine campaigns. They changed the ways we communicate, the ways we publicized the FAQs that were available through public health, what they said, what questions they asked, and the communities they responded to in ways that were across languages. And all of that wouldn't have happened without the advocacy of communities, the impacted and effective communities. And it could have been done so much sooner in ways that were respectful. I think there's a lot of learnings that we can take from some of the advocacy initiatives. And they reframe how we think about hesitancy and confidence and readiness and these kinds of things, because we could also talk about systemic neglect, systemic marginalization, systemic exclusion that puts the onus on the rest of us who are trying to make a change in how people feel trust or experience trust or mistrust within systems. It's been difficult work because, of course, there is more misinformation and disinformation being spread than the resources being distributed that provide, good, accurate, robust information. And it's hard to counter that with these small initiatives, where people are struggling to ask for piecemeal responses and solutions when there should be broad investments in these kinds of things. I think we should take into account the fact that the misinformation and disinformation campaigns have been quite successful. And some of us write journal articles and so forth, and have struggled to impact the knowledge sharing and dissemination that needs to occur differently going forward. I'll stop there. I've been talking a lot.
Thank you, Emil. That was fantastic. You touched on so many points that were so important, especially thinking about earlier on in the pandemic, how a lot of hesitancy relates to people assessing their risks. And part of that is trust, but also we also have issues with making sure it's easy for everyone to get vaccinated, not just people who can take the whole day off work and live in certain communities. And I think that early on, there was also sort of a lack of recognition of the fact that people of color are more likely to be frontline workers, and that maybe we needed to prioritize essential and frontline workers to get those people vaccinated first, because they were really taking on the biggest risk in all this. But I really liked the stories you had about the importance of community and how where the messaging is coming from is also important. Not to say that it needs to stop at community, but the community is very important in the messaging and in also trust of the messaging, I think. And you mentioned some great initiatives that really push things forward in changing things like the FAQs that were probably not written up by a diverse force of people. And so I appreciate that you mentioned that point as well. And our last panelist, Mark.
Yeah, thanks. Thanks very much, Leslie. Thank you very much for the opportunity to speak here today. So I'm just going to let you know just what my experience has been mainly with vaccine hesitancy. And it's mainly been through the Hutterite community that is in Hutterite colonies in Alberta, Saskatchewan, and some in Manitoba. So Hutterite colonies are groups of people like 80 to 120 roughly who live on their religious communities, and they live on these colonies where there's basically nuclear households. There's households, but there's shared kitchen facilities, and so they dine together, with the children and adults. So there's a lot of possibility for transmission, basically, of viral infections like influenza or COVID. So for the past, I'd say 16 years, we've been doing cluster randomized controlled trials where we vaccinate a part of the population, often children, to look at the indirect effect to see if it reduces transmission. And in doing so, we do come across vaccine hesitancy where, mothers of young children will say things like, and these are children who, recommendations are that they be vaccinated, will say, well, my child is too young to receive the vaccine. Their immune system is too young, or too early on in their development. So they're basic sort of misconceptions that occur, and that we deal with by, just speaking to them, just adopting a very neutral tone and basically responding to their concerns. So this is sort of a common theme about the early immune system, whereas in truth it's sort of the opposite. The influenza-related hospitalizations are very high in young children. So it is an important group that should be vaccinated because they're at risk. Other misconceptions often spread through these colonies because they're very well connected. They talk to each other, and sometimes there are other misconceptions. Which this is not only within Hutterite community, but outside the community, you know, people say, well, I got the flu shot and then I developed an infection. So it's very, very common that there's a confounding by season. You know, if the flu shot is given in October or sometimes a little bit later in November, there's other viruses that are circulating there, and people sometimes put these things together. And in the Hutterite community, one large misconception has been about oranges, getting the flu from oranges, because oranges, and you know, they receive some type of oranges in November, and they say, well, we get the oranges and then we get the flu. So it's often these sort of, you know, timing things that are sort of confounded by season that we you know, openly discuss. And it's important, I think, when we're talking about vaccines, is that we always give the you know, the potential risks and the benefits to vaccines, so people are making a truly informed choice about it. And that's really it. I think, you know, I think my experience is that there's some degree of vaccine hesitancy. There are some people who will, there are some colonies that are just totally against vaccines. So we don't even, you know, have anything to do with those colonies. But within a colony, sometimes there'll be an individual who has a set sort of ideas, you know, at one spectrum of vaccine hesitancy, and sometimes they can influence others, but often it goes the other way, where you have individuals who are more supportive of vaccines. So, you know, I think a lot of it is just supportive education, at least in this community, and maintaining openness to continue discussion about the benefits of vaccination.
All right, thank you, Mark. We've already got some questions coming in. And as we field them, I'm just gonna mention something that I thought really flowed through everybody's talks, and these are the reasons for vaccine hesitancy. Part of that is weighing risks, and that includes adding in misinformation, but it also includes long-term issues that are that precede COVID with our healthcare system. We also, you know, need to do a better job, I think, getting out information and making it easier for communities that are going to be most affected to be vaccinated first and fastest. And so our first question is for Lydia Joy. And I think that Emil, you might be able to comment on this as well. But we'll start with you, Lydia Joy. Have you found that the language discourse of vaccine hesitancy adopted by academics and policymakers has perpetuated mistrust and disconnect with the Black communities in Canada?
Was literally what I wanted to speak to first, so thank you. Yeah, I think even in this conversation, it's sometimes it's difficult for me, the whole term vaccine hesitancy. As a researcher, you know, I have gone into the lab with a theory of many different things that, and that's how it was discussed as a theory. It was validated and we continued forward. I find it very interesting that when people have questions or other theories, you know, we automatically say they're hesitant or that it's mythology, or we just dismiss it as opposed to the same way we treat rigorous scientific process. And absolutely, I think it has turned people off, especially in African Caribbean Black communities, because our narratives, our epistemologies, our experts have never been included as knowledge, and it are always dismissed as, oh, well, all you need is more education. When what's being dismissed are, you know, what are our narratives, and are there other knowledge that, like, is this also being validated, or is it automatically dismissed because it's not what's considered, you know, North American academia? And given the fact that a lot of, you know, the knowledge and the research and what we hold dear has been purposely systemically excluded from what is considered North American academics, you know, how can we say that we're just going to automatically, you know, take everything that's given to us and say, well, that's right, and our narratives are incorrect? So it's definitely, when we speak about mistrust and we speak about medical racism and we speak about exclusion, that is part of it. When every time we speak, it's said as, oh, that's just a myth, we just need to educate you more. I think it's been the biggest barrier. And so, I think the other thing that adds to it, Emil really touched on the idea of we had to fight to even show the disparities that were happening here, right? And that data collection piece. So again, our narratives are not included in the story unless they are validated in the way that the majority has said, oh yes, there's a problem now. But even within that, I saw so much racism come up. So we were able to see that, we're being disproportionately impacted, and again, as a genetic researcher, I know that those things that we're seeing are social determinants. They were not, race is a social construct, but yet it was all of a sudden, oh, Black people must be more prone to this, or there's something else is happening. And even in that, it perpetuated further racism and further division. In a lot of the work that I've done, it was interesting because there was so much focus on Black people are hesitant. And in the areas that I serve, it was actually pockets of Eastern European communities that were the least vaccinated compared to their Black counterparts in the same area. But yet every headline in the news was saying, how do we help Black hesitant people, right? And so, yes, I think our language matters. And the languaging that I've been seeing in the news, in community and everything else, it's not causing the unity that we'd like when we're saying, let's move together and let's rebuild. It's really reinforcing deep, deep, deep systemic differences and divisions that were present. And we have to think about how it's impacting us going forward.
Yes, thank you for that. Also, I think just to add on to your point about the ideas about race early on, I think coming out of Toronto, there were some early statistics where the Black population was overrepresented in emergency rooms for COVID, even though, I think it was 9% or something along those lines of people who were in the emergency room with really serious COVID were Black people. And that was really statistically an anomaly. And so people started saying things as what you said, is there some sort of genetic reason? But really it's their frontline workers. They're more represented as frontline workers.
Well, it's not only frontline workers. I think the other thing is, we talk about data collection, it has to be disaggregated. Like, what is the Black population? The diaspora is massive and wide, and how we interact and how we, there are different rates in different communities. And now as we've been disaggregating that data even further, like I work also with the Black physicians of Ontario, and they also had higher rates across the board, like when you even correct for socioeconomics, for positions, and et cetera. And so we have to look at what are those other factors. And I think what we advocate a lot for is when we talk about social determinants of health, we leave out racism. It's not only that there are, it's like, but why are frontline workers not having the same access to be able to isolate? Or why are there not people who are on public transit? I work in the core of Toronto and I'm on public transit too, but there's more frequent buses that are coming, or TTC or GO, where there's other areas where there's other factors of why we're seeing it. And it's not only this broad sweeping, oh, this group of people don't have access. It's really systemic that we have to change that conversation, right? And that's the thing that's been difficult to do. We're just starting to look at these things, and now how do we analyze it in a really equitable way?
Emil, did you want to add to that?
Sure. Lydia Joy really did a great job of covering a lot of the nuance there. I think what we have when we use words like vaccine hesitancy or vaccine confidence or uptake or readiness, they come with an analysis, and that analysis has a position, and that position is usually presented in terms of deficit, burden, threat, and lack. And those are bound to our histories of ableism and racism and systemic neglect, where we take marginalized groups and we see them as more at risk. And sometimes when the discourses are homogenized in this way, when we collapse them, they don't do the work for us of allowing us to see beyond that position that sees them as to blame, these groups that we're talking about, and reposition our analysis in such a way that acknowledges the fact that there are health systems and professionals and disciplines that have a job to do to do the kind of outreach that captures everyone in need, and not just the most, and thinks about those most marginalized. And if they're not doing their job correctly, where is the blame to reside? I think what has happened is we can think about people in terms of deficit and lack, and that changes what we do. It changes how we prioritize folks, and it changes conversations and how they're restricted when we talk about data collection and social determinant data and what's referred to as equity data, because what it does is sometimes it doesn't allow for us to use some of these historical critiques and analyses that have existed for generations across fields and disciplines that counter the narratives that try to say these people are more likely to be infected and therefore they are burdensome or a threat or a risk, which feeds the kind of disparity and inequity discourse that is attached to the kinds of things that we saw in early media headlines that were attached to anti-Black racism and anti-Asian racism, and those things that were being circulated early in the pandemic that were attached to anti-immigration rhetoric, that were attached to the idea of threat, burden, risk, and lack. So all that to say, I think we can be more robust in our analysis and resist some of these words that position the community as the problem, rather than the system, the services, the programs, the resourcing, et cetera.
Thank you for that, Emil. Thinking about the importance of messages from within the community and who's giving the messages and how people are being included, I was thinking about Mark's work with the Hutterites. And one of the things he mentioned was that there were colonies that took the vaccine and other colonies that were against the vaccine or didn't uptake with the vaccine. So I'm curious, Mark, what's the difference between the communities that did decide to go ahead with the vaccine and those that didn't?
Yeah, that's a good question. And because I'm not studying the communities that had no uptake, because we're not allowed having any contact with, because they don't, they're not interested in it at all. So I can't really say what they, on the surface, there's no variable like size or geographic area or anything like that's striking, in terms of a colony that can accept a vaccine. But it is more nuanced than that, because even within certain colonies, you'll get some people who don't accept the vaccines, others who don't, and actually sometimes some others will not take any childhood vaccines at all, but they'll accept the influenza vaccine. So it's complicated. So I don't know the answer to those. I do the trials. I'm not an anthropologist or a social scientist, to be honest. So I'm all I can do is describe my experience.
I was curious, even though you just told me you're not an anthropologist, I was curious if it had to do with really individuals in the community, because I had read that the Hutterites, it's the wife of the, I can't remember what the correct name is, but that she takes care of medical issues and when people need to see doctors, and she organizes that. And I was curious if this is really like a person-to-person difference.
Well, it's a good thing. The women, in terms of a portfolio, health tends to be the portfolio of women, right, on the Hutterite colony. So there's definitely different roles, and and often there'll be a lead person. So when there are sort of champions, for a vaccine, for example, that makes a big difference, I think. But I think that is one thing that's striking. But if we're talking about a sort of a colony that's fully anti-vaccine, that I don't have any good insights to.
All right, thank you. Next up, Dr. Jerry Wright would like to ask a question. Jerry?
Thank you. So this is totally fascinating to me. So I'm a bench researcher. I'm a biochemist. So when we are working with vaccine-like substances, we work with mice, and they're not allowed to be hesitant. So we got 100% uptake of whatever therapy we're trying to develop. So this is very fascinating to me, and the nuance that I think is really not something that bench scientists think about very much at all, frankly. And one of the question that I have is really, is what we've seen over the last 18 months in terms of COVID vaccine hesitancies, whether it's in pregnant women or racialized communities, and Mark touched on it a little bit. Do we see this, is it just general hesitancy for all medical interventions like vaccines or antibiotics or anything? You know, do we have the same hesitancy with childhood vaccinations, with HPV? I think I know the answer to these questions, but I'm curious to know, is there some learnings we can get from this to be able to advance all of those areas as well, to be able to target? It sounds like we need to target individual communities and individuals in different ways. But I guess the first big question is it a general concern, or is it something special about the last year, 18 months or so?
I'll let Rohan go first. I'm curious to hear, and then I have some thoughts.
Yeah, so no, that's a very interesting thing. I'm speaking about pregnancy itself. There are a number of vaccines we administer during pregnancy. And it's interesting that a person might not want to take the COVID vaccine, but might be willing to take the influenza vaccine or to take the pertussis vaccine. And I think it boils down to, for those of you who are familiar with the health beliefs model, and I learned a lot from it from one of the persons on this chat, actually, Liz Alvarez, so thank you. When you think about the health belief model, for example, it is about a person's perceived susceptibility, perceived severity, and the perceived benefit of something. In pregnancy, when we give the pertussis vaccine, it is mostly to protect the baby from getting pertussis. And that has a very different, resonates very differently with people as opposed to COVID, for example, or influenza. And so if you know that something has been tested over time, something is going to protect the baby, and there is evidence of it protecting the baby, someone is more likely to take it. With the COVID-19 vaccine, there were a number of other issues that, the first of all, the inconsistent messaging in the beginning, which said, well, the people that are at risk are those that are older, that have got diabetes and blood pressure. The younger people are fine. And then some societies actually saying, yeah, pregnant women should not be prioritized because they're not at increased risk. And then suddenly overnight to change that narrative to, yeah, you're at risk. It resulted in a distrust which was, it just worsened the distrust that there was. And then when it came to, the mRNA part of it and the fact that the vaccines were rolled out so quickly, there were a number of issues specific to the COVID vaccine that made people more hesitant among the pregnant population, at least. So yeah, to answer that question, I think it's not a general, I don't like the term vaccine hesitancy either. It is a reluctance to take some kind of medical treatment comes from a number of sources, and it's not generalized. It is most people make a risk-benefit analysis and they determine what is right for them, and that is based on a number of factors. Some of them community-based, and some of them very personal or individual, and therefore it doesn't go across all medical treatment or all vaccines at all.
If I can just add to it, so I agree completely with what you're saying, and then to add the lens of you're asking, has this been similar for other drugs? So what I found very interesting in African Caribbean Black communities is, I would say yes. And what was, very disheartening was when all of a sudden, we didn't collect information before. This is the importance of data collection. So if we don't know what the uptake was in different communities for flu vaccine or for other things, because we don't collect this disaggregated data. We know within community that, yes, we've had these narratives before of I know many people who've taken nothing other than the actual mandated vaccines, but that have been around for a long time, as Rohan said, things that have been proven that you've done your risk analysis for. But what was really fascinating at the beginning of the pandemic was that we've been excluded and haven't done this for a long time, but nobody cared. And what was, I think, added to this idea of, this isn't really about us, was it was only now important because we might infect other people, right? And so it became this like, oh, maybe you're a vector, or maybe you're a frontline worker, or maybe you're caring for our family. So now it's important that you take part of this public health measure. But when all of these other vaccines were happening or personalized care was happening, nobody was checking up and saying, let's see if this uptake is happening in these communities that are more vulnerable. Let's see what mortality rates are like. Let's see who's being impacted. Nobody was really concerned about researching or checking. So we don't know. I think we don't know the actual numbers to what you were asking, because it wasn't a concern until it now impacted everybody. It wasn't important, if Black communities alone were not being vaccinated for the flu, it could have been a 0% uptake. Nobody recorded this and nobody was concerned. It's only now a concern. And I think that's one of the other lessons that we have to learn. If we want to really keep saying this is about public health and we are in it together and we will support each other, these type of questions are things that have to be asked all the time, that we know who is partaking and who is not, who is included, what are beliefs, and who is being impacted, so that we can have those tailored conversations as you were bringing forward. And I think this has been like a great exposure of where our priorities have been before this.
Great, thank you. Do any of our panelists have anything to add to that on that point?
Well, I can say that in terms of, again, my own experience, that there's been a reluctance around the mRNA vaccine in particular, because of the, I guess, because it's a new technology, because of the rapidity of development, and somewhat ironically, I mean, it's just, among the highest efficacy in terms of the COVID-19 vaccines. But I found that there's been a greater reluctance around those vaccines in particular in the Hudrid, and as well as in sort of more mainstream communities.
I think there's another question in the Q&A, Mark, that I think you sort of answered, but I'll just read out the question for you. For non-pandemic vaccines, does the strength or quality of scientific evidence behind a vaccine's efficacy, safety, et cetera, have a significant influence on hesitancy?
That's a good question. So just to reframe that, you mean the quality of the evidence, whether it's a randomized controlled trial or a test negative design, does that have an effect? I honestly, again, it's just my experience. My experience is that doesn't, because it's beyond the, it's beyond the clinical science. The reasons, at least in my experience, for someone not to take a vaccine is not that, well, I was worried that there was bias in that observational study. It's totally different. It's much more of a belief, I think, that the potential adverse effects outweigh the benefits, and that frankly, that's not in the science. So I think it's beyond that. I do think, of course, that when you're working in public health, and you want the best level of evidence to support what you're doing, that's very important. But I'm just, my own experience is that when people don't want to take a vaccine, it's not necessarily that they're not looking at the quality of the science, in my experience.
Great, thank you, Mark. We have another question from Liz Alvarez. And her question is, how can we approach the paradox that we want to collect more data on gender, ethnicity, et cetera, but that more people don't want to provide personal information? Any approaches or thoughts? And I'm not sure if this would be more towards Emil, maybe?
Sure, I could start. You know, I think people are at different stages in terms of appreciating the need for some of the data and what kind of conversations we're having about it. You know, like I was alluding to earlier, we don't want to be in a situation where we're used as, you know, crops for cultivating data that don't benefit us, that are extractive, that are used in ways that are told or sold to us as beneficial, but are really wielded in ways to suggest that the doing of the doing is the collection of the data, instead of using the data to inform knowledge that is used for change and transformation and impact. And we also don't want to be in situations where we're used as data that highlights disparities and inequities that put us in the camp of those to be identified in terms of blame, risk, threat, burden, and lack that set us up for attack. I think, you know, some of these conversations aren't new at all. You know, we have the OCAP principles from First Nations communities that think about ownership, control, and access and possession inside of social, historical, and political contexts that recognize the use of quotas and tokenism and ways that data has been wielded in negative ways and harmful ways. You know, we have the out of Toronto, the EGAP principles, where Black leaders and Black community members are telling health systems and services, we need data to be connected to change, and we need to be a part of the process of analysis and a part of the feedback loop, such that we know what's happening with us, for us, about us, and those kinds of things. Those tools exist. They have for some time. Some of them are rather new. They're very nuanced. And some of the engagement with Indigenous communities have been processes that are, you know, in 10 years in the making or more. And we can draw on that knowledge and use it well, instead of beginning from a position whereby we're pretending that we need data to prove that disparities exist before we take action. We're not there. We know they do. And there are people we can listen to that know what they're talking about to help us move things in such a way that we're not starting from scratch every time we talk about equity seeking groups or marginalized groups or you know, those left out.
One of the, oh, sorry, go ahead. No, you go ahead.
I was just going to add to that. So I actually did work on the EGAP, and I think, you know, it's really what you said. This is not an extractive process of going in, it's partnering. I think how do you alleviate that is that you truly have to be transparent of why are you collecting the information? Who is it going to benefit? And those who are able to hold their own information, because we've had too many examples when how it is assessed, how it is applied. You know, we've given this information freely, and then it turns around to be to our detriment. So I think this is really an opportunity of, we need to build capacity within communities who are the most marginalized for us to be able to process our own research. So this shouldn't be an external process, right? This should be that within our communities, if we're saying there are gaps in Black, Indigenous, and other communities, build up researchers within those communities to own that information and be able to help according to the needs internally, and then let us partner outwise instead of the other way in. You know, we always have this conversation of like, who's invited to the tables? Let's have multiple tables and let's convene on our own terms. And I think that really has to be part of it, because we are overcoming a lot that we're not coming just saying, you know, we trust what's going to be done with this information, but we can build that by building capacity within community.
I'm going to paraphrase something that both you and Emil said in different ways. And that is that as a community, we need to start thinking of people who have traditionally been excluded as being part of the process and as being partners, not as reagents. Because as Emil said, you know, there's who owns the data when we do this, and who is in charge of analyzing that data and generating that data. There needs to be a real partnership for the people that are affected by the collection of that data, and we need to make it more of an integrated community. So my question is, how do we do that? You did mention some ways. I think I'm more thinking, you mentioned a lot of ways that the individual communities tried to push that forward, but what does the government, public health, all of our agencies, what do they need to do to make this happen?
I think, all of this builds on everything everyone was saying. There is a shift in your perspective when you appreciate that the position of being the hesitant, the mistrusting, is a place of knowing. There's knowledge there, and knowledge that our systems haven't ingested, incorporated, operationalized, and implemented. And if you see that as a need and it's important, then it's also important to value and appreciate the need for that knowledge and resource it effectively, such that you're boosting those knowledge contributors, knowledge makers, so that they inform systems and services in ways that are impactful, rather than suggesting we're doing a thing, we're doing it well, and these people are the problem. I think there's a analytical shift there when we do the work initially of thinking of ourselves and our own systems and structures as complicit.
Thank you for that. We have just a couple of minutes left. So I'm just going to take the last couple minutes to thank everyone who came. And we have a couple more questions that are in the chat as well that I think the panelists can see. So if they also wanted to answer any of those, they're welcome to do it. And so in terms of bringing more vaccinations to more people, I'm going to ask the panelists, and you don't all have to answer, but if anybody wants to jump in, which panelists are you going to collaborate with to increase vaccination rates?
Let me just answer that. So we are currently working with our partners at Health Nexus, which is a not-for-profit organization, and we are working with marginalized, racialized communities and indigenous populations. And what we've realized is, in response to some of the other things that were said earlier as well, is that it's not just about the quality of the data, it's not just about all of those other things which are important. It's also basically, it all revolves around epistemic trust. And it's so important that messaging is clear, concise, and honest and transparent. Just saying something like, oh, vaccines are safe, there are no adverse effects. How do we know it? They've not been around that long. There can't be long-term effects. There are no long-term effects. We don't know that because we've not had a long-term since these vaccines have been rolled out. So the messaging sometimes from healthcare professionals as well has been it's been quite paternalistic, it's been dismissive. Some of the concerns have not been heard. And so rather than I think one of the things that health systems and health policymakers, et cetera, could do and need to do is to engage and to listen, to understand what the concerns are, and then to build the narrative or to build directives or whatever else needs to be built based on that, on the input that they receive, rather than having this top-down approach. And we found that has been very helpful, engaging with communities through members that those communities trust, asking what specifically their concerns were. And many of the concerns that were brought up by communities are very different from what we thought the concerns might be. So not generalizing, not assuming, and just finding out what their concerns are, addressing those. And that has really helped. People ultimately want what is best for them and for their babies. Nobody wants to deliberately cause harm to themselves. So if they're not willing to take something, it's because their understanding is that is not better than the current state that they're in. And just appreciating that has helped us understand and help a lot more people.
Right, thank you for that. Unfortunately, we are out of time. We always run out of time and everyone always wants more discussion. But I just want to thank all of the panelists who gave their time today to educate us on some very important issues in vaccine uptake. And we will have our next Nexus conversation in June. So stay tuned for that. And thank you all for coming.
Thank you.
Thank you.
Thanks, everybody. Much appreciated.
Thank you both so much.
Okay, we'll see everybody soon.